Good morning, everybody, and thank you, AIOS, for this opportunity. And I'll be speaking on open sky cataract surgery. So, to start with this video, this is a video of triple procedure. So, normally, when cataract is significant or and cornea is scarred, we need to combine these procedures. So, in this triple procedure, first of all, we have to remove the cornea. And after removing the cornea, you can see the bulky nucleus here. And sometimes it is very simple and easy procedure, just you have to tap it and it will come out. You can see the AC is quite deep, there is no upthrust, so these cases are very simple and very easy to perform. And then lens is placed in the bag and the procedure is done. So if we talk about the indications of cataract surgery with penetrating keratoplasty, so if the cataract is visually significant, corneal perforation with lens plastering on the cornea, high vitreous upthrust, ruptured anterior capsule, subluxated cataract, intraoperative lens damage. So these are the indications for combined procedures. And if you talk about the challenges, the problem in intraocular lens power calculation is a main issue because most of the time the corneas are scarred, you don't get correct keratometry reading, so you're not sure whether the IOL power is correct or not. So in many cases, we take the help of the other eye. If the cornea is clear in the other eye, take the K reading from that eye and axial length of this eye, and then do the IOL power calculation. Difficult surgical technique in terms of when there are synechiae, a small pupil, high vitreous upthrust, ruptured capsule. So these cases, these patients have high upthrust. Intraoperative pitfalls like this, performing CCC is challenged if there is a vitreous upthrust. IOL implantation in the bag is very difficult with high vitreous upthrust. Cortical metal removal in small cases, because with the bimanual irrigation aspiration cannula, you get a lot of reflexes and you are not able to see clearly where the cortical metal is. Posterior synechiae in most of these cases, because they have a very high inflammation pre-operatively, and despite all these, you get refractive surprises. So pre-operative preparations, we have to look for the lens status, how dense it is. Early cataract, we should avoid doing cataract surgery and do it as a sequential procedure. And any signs of peripheral anti-synechiae, phacodonesis, we have to look for the IOL power. If involved eye has a bad cornea, with the IOL power can be calculated to the other eye after checking the axial length. And pupillary dilatation with the mydriatic. Intravenous injection mannitol is very important in all cases of combined procedures. The standard dose of 3 to 5 milligram per kg body weight has been given. And I also gave tablet acetazolamide 250 milligram, 2 stats with mannitol. And good ocular massage after local anesthesia should be given to reduce the posterior vitreous pressure, and avoid massage in cases of perforated corneas. So this is one of the case of microbial keratitis. You can see the infiltrate all around the cornea, central perforation. You can see the lens here. So Fleringa rings works very well in these cases. We have to use Fleringa ring to avoid sudden decompression of the globe. And then it is cut. You can see the lens is already out, and because the capsule was ruptured, so just remove the lens. With the Fleringa ring, the surgery becomes very simple. If it is not there, it will keep collapsing and risk of choroidal hemorrhage is there. So large graft. And we have to size the use Fleringa ring sizes depending on the graft size that we are going to take. And so this is one complication that I had last year. And after removing the patient's cornea, when I was trimming the ledge and preparing the graft to put it, you can see the lens here. It's already absorbed lens. This was a case of repeat keratoplasty, and within few seconds, I just saw that whole content is bulging out. And before that, I could have done anything and started profusely bleeding. and this was devastating. And because this was the first time I was encountering such complication, I was not sure that what is going on. And then I just put the same patient's cornea and put the finger on that and wait for bleeding to stop, given the intraoperative mannitol also. But the damage was done. And then I closed the eye. The pressure was so high, I was not able to suture with 10-0 nylon. I have to use silk sutures to close this patient's cornea. So this was a nightmare. And every time now I operate triple procedures, I get scared with thinking of this complication. So it's better to take double precautions, use all the things that you have with you to avoid such complications. You can see the silk sutures here. So luckily the patient eye was salvaged. All the vision was not very good, just a 1 meter vision, but eye was salvaged, no phthisis luckily for the patient. And so to avoid such complications, to avoid vitreous upthrust, now people have started doing stepwise procedure. They reduce the pressure either preoperatively or in the same procedure, just a pars plana vitrectomy to decompress the globe, and then open the button. So this technique works very well in many challenging cases. This is another aspect of just I'll take 1 minute. So another aspect of triple procedure is the small people, because most of these patients have inflammation pre-operatively, sphincter damages, synechiae. So in these cases, Malugin rings works very well. Like cataract surgeries, you can see this case, brown cataract, non-dilating pupil, just put the Malugin ring. And this is very simple, and just tap it, and this big bulky nucleus is coming out. You can put the lens under direct visualization, and surgery becomes very easy with the Malugin ring. And lens is placed, and you can see this. And last thing is a Zepto device also works very well for small pupil cases like this case. You can see there is a dense vascularization with a scar, and once I remove the cornea here, it was a non-dilating pupil. So gently you have to lift the iris, place this Zepto device under the iris, and once it is secured on the lens, centered, and then just press the button, and the rhexis is done. So without visualization also you can do the rhexis in these cases. So Zepto helps a lot in such scenarios.
I think Dr. Bhufesh, you need to stop.
Yeah.
No.
And the surgery is
already
done.
1 minute above.
Thank you. So it was 7-minute talk, I think. Thank you so much.
Yes. Sorry for that. Next speaker is Dr. Navneet. And Dr. Bhufesh, the entire is like a lid. It's like a lid.
Lid type.
Second thing is that, whenever you get such a situation, let's hope nobody gets it. But rather than taking sutures, you just pass the needle, take 10-0 multiple sutures, just pass the needle across sclera and cornea, keep it like that, and then you will get time to suture.
Very nice. Thank you so much.
So, please.
Dr. Bhavesh,
Yes.
one question, just last question. Yeah, like in perforated cornea and all the things that like anesthesia is also very important. So how you give how much anesthesia? But you
perforated cases, it's very challenging. So what I do is give 2 ml anesthesia and then wait for some time. Again, 2 ml anesthesia, because if you go give 10 ml in one go,
one option is like you can go for a parabol also, like along the subtenon.
okay.
Rather than going behind the eyeball, you go along the subtenon. So conjunctiva and sclera is almost anesthetized, so that you can work on that, just controlling the eyeball movement. That's all.
So the general rule which we follow in our institute for any such situations where we require an open sky technique is GA. There is absolutely no local or parabulbar or peribulbar given. It's complete GA, and which does not increase the intraocular pressure. That is.
Fine. Thank you. Dr. Navneet is going to talk on happenings in phacosurgery.
Good morning, respected chairperson and colleagues. Happenings in the phacosurgery, the things can happen with anybody, anytime. Video start. There are very few conditions I am just showing. This we are taking limbal incision, and what happened, see here. suddenly crescent entered. It's not a simple situation to tackle because the opening is different and you have to do phaco surgery after that. So then the whole procedure change. You have to, instead of side port, you have to use the main port for the preparation of the capsular access. And here it is the discoloration, which is the very important prior to surgery, that anterior chamber should be with the one solution only. It should not be mixed with the many solutions. All these things can get mess, but we can manage. But this has happened and we have to tackle. We have to remove out the bluish discoloration. And this is the very important step. You go in the entry and try to find out, and it should be 2.8 or 2.2, whatever we decide. Another case, mature cataract. And there is a stretching. You can see the two folds of the, suddenly this thing can happen. So there is a stretch on the zonules. We can manage, we can complete the capsular access. But most important thing is that we have weakened that zonules. So all the pressure during the next steps, we have to avoid in that area. That is the intention of this presentation also. Things can happen, but you have to be focused that this zone is weak now and we have to tackle. I was removing the nuclear pieces and suddenly I noticed the bluish discoloration in the vitreous cavity. Because sometimes it may be excessive use, sometimes it is the micro leakage, sometimes is the micro zonular weakness in one quadrant, we don't know. But you have to be careful, you cannot do anything else. This has happened with me in 2007 at Jordan when I was doing live surgery. I have put PMMA lens at that time, by scared. Now here, now this is happening every day, but you have to be careful and you have to tackle. During the irrigation aspiration, all these situations is happened due to our fast, quick mind, quick movement. Sometimes we are in a hurry to finish the one case to second case. And I was completing, and suddenly I catch the PC. It's just simple direction of your IA cannula, change little bit downside and you catch PC. A very simple case was going on and this thing has happened. This is another case in a finishing step. I have put the lens. I was comfortable. I was talking with the patient. Patient was known to me that everything has went well and you are all right. I was just doing simple irrigation and see the thing. Everything was looking okay. See, suddenly the back came out. I don't know what to do at that point. And just keep patience quietly. Suppose immediately we start thinking of CTR, this thing, that thing. A very simple trick I have thought, that just we will put the fluid first chamber, make the chamber normal, and just put the fluid towards the direction of the back and it gets settled. That's all. So anytime anything can happen, and then it is the tense eyeball, everything went back and the thing has finished. Yeah, 1 minute, yes. Yes. There was a thread in the cannula. I have removed it. This is the just one case I am showing 8 days before, 10 days before I was doing. So that is the first happening in that case. Then again, I was trying to do and suddenly nuclear piece has come. So up to the last moment, you don't know what is going to happen. And this is always I try to tell during my surgical training program and all that. Those after 5 years, 10 years also people are coming for training. I just salute them. But then I teach something different. You should feel the surgery. When I saw that this case was a hypotony, so these events will be happen till last moment. Because in hypotony, pieces can go in the angle and anywhere. And when you start in a finishing step, especially if it is a fast cutting machine, some small piece like this will go. So happening in phacosurgery is such a topic is that can happen. I have a collection of 200 to 250 cases. Everyday thing is happening. I am just recording and now that collection has started. And that will be helpful to all. This is just to share. Thank you. Thank you very much.
Thank you, Doctor.
Dr. Namni, just one thing. That you
while
should.
the comments are going, I would request the next speaker to just get ready with his talk on the podium. That is
Dr. Sataraj.
Yeah, Dr. Navneet, you were showing that case of dialysis, which you try to settle with just with the fluid only.
Yeah.
But I just share with you, like once the zonules are broken, because that's why only dialysis happens. So that doesn't settle. But it is always better to be on safer side. Just put a CTR ring with the IOL in place, so that will be settling in a much better way and safer way. That will be long lasting. Because once you fill the bag, that will go back. But once that bag is not that inflated, so again dialysis will come forward. So it's better to put a CTR. Yeah, thank you.
those are very, very nice cases, everyday cases which we all encounter. So while he's getting set up, a little bit of discussion on the first case you had, premature entry in SICS. I would just suggest not to overinflate and just general, not with regards to what you did, general tips about not to overinflate the whole chamber, because then the iris starts coming out and that's where things go downhill. And when you got the PC, I could see that there were shadows of the drape, eye drape. That's also very common in our situations where the eye drape, just comes and disturbs us in our visualization. So just keep the eye drape away. So we'll go with the next talk as he is ready. Thank you, sir. Thank you very much.
Good morning, everyone. I'd like to thank the scientific committee for giving me this opportunity today. So today we'll just discuss something that's not very clinical, but a little paraclinical, which is cataract workflow. As cataract surgeons, every patient who's coming in for surgery, we have to work them up. There's a process that they have to go through. Some of us who do more surgeries, this is something very relevant. So let's just discuss what all technologies we have available today. Financial disclosure, I am a consultant for Carl Zeiss Meditech. So today when we have a patient coming in, the conventional workflow that we follow is that we'll first do a clinical examination, we'll perform biometry for this patient, the patient will undergo counseling where they're explained about surgery, the different options that are available, then probably the patient will come back to you with more questions, you'll discuss those options, probably finalize one, then you'll ask for new biometry printouts so that you can select the appropriate lens power. You might want to do some online calculations also to double check. Then you will find out about the availability of the IOL power in your stock or with the company. Then you'll go ahead, schedule the surgery for this patient. Then you will go ahead on the day of surgery, retrieve all the relevant data that is required, confirm everything on the day of surgery, do a timeout, confirm the lens power that is available. And by the time this whole process is done, we're just so relieved the surgery is done that we rarely ever even bother to do anything with the post-op data that we're collecting. So, there's a lot of redundancy in this whole process. There is a lot of back and forth for the patient, for your own staff. You'll get repeated printouts of the biometry. If the patient decides to change anything, you'll have to do calculations over and over again. And most importantly, there's a significant chance of errors. Some studies have shown that in medicine, transcription errors alone can be almost 5%. So, you can end up with IOL surprises. And sometimes when we have a refractive surprise after surgery, we try to find out all the different causes, but we might never pick up that it was actually just a data entry while calculating the power. And again, when we are trying to use these newer online calculations that are available, because we're entering the data again and again in different places, the chances of these errors will only increase. So, we have these digital operating tools that are available to us. So with machines such as a good biometer, we are able to capture the data we need. With EHRs and with solutions that are provided, for example, by Zeiss, which is the EQ Workplace, we are able to process this data. Then we'll have apps which can actually help us counsel the patient, educate the patient at the convenience of their home, on the convenience of their phone when they're in the waiting area. You can then process that data and then utilize it in something such as, markerless toric surgery. When you talk about EQ, the best part about technology is also that everything is relatively seamless. So this data that is available, since it's not a hard copy that is present somewhere in your office, it's available everywhere. It can be available on any device that you're using. You don't have to necessarily be at the office. You can do all your calculations, all your planning sitting at home, so that it saves time for you when you're actually in the OR. The other great thing is that with all this data readily available for researchers, it makes things much more efficient and effective, and it's very convenient to pick up data for when you have to make a presentation also. So one thing that we might be relatively more familiar with is the whole markerless toric surgery platforms that we have available, for example, Callisto. So if we talk about, when we normally want to plan a toric IOL, we'll have to do the same steps: clinical examination, keratometry, A-scan, calculate the IOL power, then mark the references in the OR, and then perform the surgery. But if you move to a digital tool, markerless toric surgery, we can reduce that down to just 3 steps, which clearly saves a lot of time. But studies have actually shown that even beyond this, if you just repeat the same process with something such as EQ Workplace, which is a whole cataract flow solution, you'll actually save a further 4 minutes per case. So the NHS also did a study on never events, which are mistakes that happen because of, again, data entry or operating on the wrong eye. And the reasons that they found was they can be just poor communication between you and the patient. They can be poor management of your records that you're maintaining. You did not check the data properly before planning the surgery. Again, planning the patient, marking the patient was not done accurately. Within the OR, there can be poor communication between different staff members, leading to errors. IOLs, maybe someone picked up the wrong IOL. And if you just don't, even if you impose protocols, it's very difficult to make sure everybody is following them. So there are a lot of chances of errors that can happen and which can affect the patient significantly. So again, when we talk about these digital cataract workflow solutions, we can really help avoid a lot of those errors. We are talking about an OR or a solution where we have a patient come in, all the work examination is done on a biometer. That data comes to you seamlessly in your office. You look at it, you talk to the patient, whatever IOL they have, you have the data readily available over there. Anything you want to change or alter in the data, you can do that. Now, you don't have to keep going back and forth between machine to find out that, are you suitable for a premium presbyopia correcting IOL or not. All that information is readily available to you. You don't have to re-enter the information and again and again. You can have an app which will help. You discuss with the patient that, okay, this is the IOL that we are considering. The patient opens up the app. The patient can read all about the IOL, the different negatives, the different positives, and make a much more educated decision. And then all this data is automatically sent to your OR. You can visualize this when you're operating. You can actually now control the steps of cataract surgery, everything, including digital marking, right from your phaco machine. You don't even have to have someone do the marking or the calibration on the microscope. It really helps streamline everything, save you a lot of time in the OR. With new apps such as iGuide, again by Zeiss, you can have patients take well-informed decisions about what their options are. You can give them checklists, so when they come in for the day of surgery, they're better prepared. They know what they have to go in for. They can have reminders for their drops and post-op visits after the surgery. And we're hearing a lot about AI, and Chat GPT has really come into the commonplace. So everybody's talking about it. We do have formulas that have been available now for a few years, which are based on machine learning. But at the AACRS this time, there was actually some data presented which showed that the new formulas, which are incorporated into the new cataract workforce solution, which is Veracity by Zeiss, it is actually more accurate than any other formula that is available right now. That is the advantage of something which captures data end to end. That it is capturing data seamlessly, it is able to utilize that data, so it's not dependent on you uploading that data. Some of the limitations that will be there obviously are cost, but again, since it's cataract surgery, the economies of scale kick in, because you'll do a lot of these, so you will end up using this quite a bit. There is vulnerability with any technology, any server downtime, you'll be trapped. And yes.
You need to wind up.
Last slide. And obviously, you'll be confined to one ecosystem when you use this. Just same thing summary, that you save time, reduce errors, you better educate your patients, and you get to analyze more data. Thank you.
It's a very nice talk, Sarkar. We'd like the next speaker to get ready while you take your questions.
Yeah. So in industry safety, there is something called as Hindrich triangle.
Mm-hmm.
Okay, for every 30,000 unsafe actions, there are 300 near miss events, 30 minor accidents, and 1 fatal accident. So if we keep on increasing the time till which we make these 30,000 errors, the safer we are going to be. It is never going to be zero.
Absolutely, you're correct, sir. Even with these technologies, it'll never be zero. But as long as we can reduce that as far as possible, we are helping out our patients. Thank you, sir.
Very nice.
These cloud-based solutions are quite nice, and they do reduce the human error which is there. But also we have to understand we need that human interaction still, as we are doctors and we are dealing with doctor-patient relationship. So everything cannot be substituted by the cloud.
Good morning, everyone, and thank you so very much for giving me the opportunity. So my talk is on swab source optical biometry on the IOL Master 700. I have no conflict of interest and no financial gain. If we talk about all the closed cases, the second most frequent cause of claims is because of the biometry errors and wrong IOL power calculation, and it results in payment of damages in 62% of the cases. That is a staggering figure to look for. So what are the advantages of swab source in measuring the axial length? It measures to the center of macula along the visual axis, thus it calculates the refractive or the optical axial length, unlike ultrasound biometry, which calculates the anatomic axial length only. The visual and geometric axis, they do not coincide, and the IOL power calculation, optical axial length is the foremost important. Ultrasound biometer measurement are till internal limiting membrane, and since average thickness of the retina is 200 microns, the distance between ILM and the photoreceptor layer, the earlier methods of IOL power calculation used to add 200 microns to the measured axial length. Retinal thickness vary from 160 to 400 microns, and these optical biometers measure the true axial length from the anterior corneal vertex to the photoreceptors or up to the Brooks membrane. And the use of a shorter wavelength yields more precise axial length measurement. The accuracy of axial length measurement with ultrasound is approximately 0.10 to 0.12 millimeter compared to 0.012 millimeter for the optical axial length. It is a non-contact method. Rigid ultrasound biometry tip can cause corneal indentation between 0.1 and 0.3 millimeter, resulting in error from 0.3 to 1.0 diopter in the IOL power calculation. Accurate biometry in pseudophakic and aphakic eyes and eyes with phakic IOLs. Also, the axial length measurement is less affected by the type of IOL material. More accurate measurements in myopic eyes with staphyloma, in children, and silicone oil-filled eyes. There is no need for velocity conversion equation in such kind of patients. So this is the IOL Master 700 developed by Zeiss. So it provides full-length OCT image of the eye, and the device performs 2000 scans per second, and it can identify unusual ocular geometry like the crystalline lens tilt or decentration. especially when we are going to implant the toric IOLs. So regarding the basic technology, it has a B-scan star pattern, and it is a swept source type of OCT, B-scan biometry, and unsurpassed analytical potential. So it leads to fewer refractive surprises because the swept source biometry facilitates a full-length OCT scan for visually verifying measurements and detecting unusual eye geometries. The fixation check and telecentric keratometry for the robust measurements. It provides all parameters for the latest IOL power calculation formulas like the axial length, anterior chamber depth, lens thickness, central corneal thickness, white-to-white measurement, keratometry, and reference image for the cataract suit markerless. So the key features are scan depth of 44 millimeter, scan width is 6 millimeter, fixation check width is near 1 millimeter on retina, resolution in tissue is 22 microns, and speed is 2000 scans per second. There is a standard deviation of repeatability, CCD plus minus 2 micron. Anterior chamber depth plus minus 10 micron, lens thickness plus minus 19 microns, axial length measurement plus minus 9 micron, and keratometry plus minus 0.7 diopter. So it optimizes our workflow in 99% of the cataract. Even it penetrates the hardest of the cataract. The axial length measurement with the partial coherence interference biometry fail in 6% of the patient. The IOL Master 700 with swept source biometry shows a cataract penetration rate of 99%. That means 92% fewer ultrasound cases. And fewer ultrasound cases result in fewer refractive surprises. So fixation check is very important. So we need to look for the foveal pit. If it is there, it means good fixation. If foveal pit is not there, it means the foveal pit is not visible and it's poor fixation. So there are a few examples. So these are the measurements.
2 minutes.
Yeah. So good fixation, see the foveal pit. We can, and only 10 micron difference in the axial length. So it's a good catch. Only 0.02 diopter difference in the keratometry. So it helps to identify the errors. Poor fixation because the foveal pit is not visible. 190 micron difference in the axial length. So we need to repeat in such cases. And more than 0.5 diopter difference in keratometry. Again, we need to repeat it. Vitrectomized eyes, there is no use of the conversion factor in the IOL Master. So in summary or conclusion, get fewer refractive surprises by using the IOL Master and OCT image-based biometry for visually verifying measurements and for the detection of unusual eye geometries. So it improves our refractive outcomes, repeatability is there, clinical foundation, telecentric keratometry, and biometrical parameters are there. So it optimizes our workflow with good penetration rate, on-board toric IOL power calculation, easy delegation, measurement speed, markerless implantation of the toric IOL. Thank you. These are my references.
Thank you, Dr. Arvind. Dr. Ashok Nanda, yeah, please. Dr. Arvind, you could elaborate a little more on telecentric keratometry. It is one of the very important features of IOL Master 700. Basically, it is distant independent, and that is what increases the accuracy several fold. Then there is a now facility for central topography, which can be which helps a great deal in planning for torics. And the third thing which IOL Master 700 gave us is Barrett-TK formula. Now it is available in many places, but originally it came in IOL Master 7, I think 500 or something.
500.
500. So I think those points also should have been mentioned.
Thank you, sir.
Yeah, Dr. Arvind, as mentioned by him, like especially in post-classic cases, the central topography becomes very, very important.
Yeah.
Yes, very good.
Thank you.
Good morning, everybody. So even though I'm publishing my experience in a new phacoemulsification machine, which is the Quattera 700 from Carl Zeiss, I have no financial interest in the presentation. So the key benefits of this particular machine, Zeiss Quattera 700, are the main three, which I am going to elaborate today. Digitally integrated surgical workflow, the patented Quattro pump, and the automated ultrasound power on demand. The digitally integrated surgical workflow basically allows you to connect your other devices to this phaco machine so that there is efficiency in your management and a better outcome. You can integrate both IOL Master 700 and Callisto Eye, and also it has a facility to actually integrate with a microscope so that you have a microscopic view of whatever the surgeon is seeing, and that helps in a better assistance by the nurse in anticipating what is coming up. By integrating with Zeiss Callisto, of course, you can have a markerless system for putting your toric lenses. You can control everything either through your intuitive user interface, which is a touchscreen, or through the foot pedal control. Then, of course, by looking into your data from the IOL Master 700, you can have a paperless check, and there is less risk of any transcription error, as already has been pointed out by the previous speakers. Most interesting is this quattro pump, which is patented, and the mechanism is completely different from almost all other fluid dynamics that are available. There is a synchronized fluid exchange system, and it directly measures and synchronously controls infusion and aspiration in real time. The surge control is excellent. IOP recovers in 200 milliseconds, and it is not dependent on the vacuum limit or the IOP, which is IOP level, which is set. It has a facility to real-time measure the infusion and aspiration volume, and therefore it can calculate what is the leakage from the incision, and it can compensate that leakage. If you look at the quattro pump fluidic panel, you see there are 4 blue dots, which are actually inductive sensors. These inductive sensors actually measure the irrigation and aspiration flow, and 4 pneumatic ports that controls what is the volume of the fluid which is going to go in or come out of the eye, and 1 irrigation pressure sensor that actually monitors the irrigation pressure and maintains the IOP. Once you go to the cassette, you can also see that there are 4 chambers. There are 4 chambers, out of which 2 are irrigation chambers and 2 are aspiration chambers. And these chambers have a membrane, and this membrane is controlled by the air coming in through the pneumatic port. The pneumatic port is connected to the pneumatic pump, which is there inside the eye. There are 2 pumps, and these pumps receive information from the sensors. And if there is a requirement for more fluid to go in or come out of the eye, the amount of air which is pumping into these membranes are more. Therefore, it increases the speed of the flow, and it also compensates. So if you see, this is an animated video. When one cassette or one chamber is getting filled, the other is getting emptied, and they are synchronously happening both for irrigation and aspiration. So there is no chance of any surge. And lastly, it is the automated ultrasound power and demand. So what does that mean? It helps not only to reduce the amount of ultrasound that is used, it also improves followability. The machine has an intelligent system of knowing when the phaco tip is getting occluded, and automatically the ultrasound is switched on, and the occlusion breaks, it switches off to a minimum level. So this helps the surgeon to remain more relaxed. He doesn't have to constantly press on the foot pedal to fiddle between the ultrasound and the irrigation modes. So he can remain more relaxed throughout the surgery. Before I conclude, I'll just show a video where a fairly hard cataract is being emulsified, and mind you, the flow rate is almost 90, and the vacuum is almost about 800. You can notice I did not have to make into very small fragments because the followability is good, and you can actually catch hold of the nucleus pieces without having to worry about those pieces being thrown off from the tip. And you can also see the chamber stability without any surge, how fast and smoothly the machine works and efficiently it completes emulsification. Over that, it also has integration with imaging systems. So obviously, whenever you have a case of toric lens or a multifocal lens, you can utilize that facility. to improve the surgical outcome. So to summarize, I would say this machine has advantages not only to improve efficiently the outcome of surgery, but also to make the surgeon more relaxed, so that if he has a long list, he would not be tense in doing surgeries. Thank you.
Thank you, Dr. Ashok, for your excellent presentation. Just like to add two things only. One thing is the surgeon who operates, that matters more than the machine. And secondly, like you showed that last case, you were not breaking much the nucleus. Even if you break in small pieces, then you can just aspirate it. You're using less of the phaco power, even that will be better option.
No, this video was made just to
I
demonstrate.
I understand.
That even if you just
But
make 4 pieces in a heart
still,
catheter,
you are giving a carry home message. That will break nucleus as many pieces as possible. Thank you for your excellent presentation. Thank you.
I did a very good talk. Next, while it gets set up, it's definitely a fantastic innovation by Zeiss.
Good morning, everybody. Thank you, Dr. Somil. So my talk today is MyLoop, the new way of pre-chop. So these are my financial interests. So it is a tool by which we can do the chopping before we start the phaco, and it is reduces the phaco power by around 30%, and also there is a reduction in the overall phaco time, the procedure time. So it can be used in dense cataracts, compromised zonules, and fuchs dystrophy, where we require some adjuvant for phaco. So it has got a, it's a single-use nitinol loop. Okay, you can see the loop over there. Okay, this loop will constrict. Once you withdraw the piston, it will constrict and it will break the cataract into 2 pieces. Let us see a small animation. So it goes around, because of its shape, it goes around the nucleus very easily under the capsule, and you can, by first chop, you can divide it into 2, and by the second chop, you can divide it into 2 more. That means total 4 pieces. Now let us look at the step-by-step guide. First of all, entry. We have to lie it flat while introducing into the anterior chamber, and then introduce it. Take it on one side. If you are right-handed center, take it to the right side slightly and start expanding. Let it expand under the capsule. As it goes under the capsule, just goes in slow steps, so that it and you allow it to expand under the nucleus. So this is what is done, that it will expand under the nucleus. Over here, one of the most important thing is to look for silver reflex. You can see that a red mark is there. That is a silver reflex. That is basically the lower arm of the tineal loop, which is coming. That has to come right below the loop in the anterior chamber, the part in the anterior chamber, and then only you go for cutting. Now this is the way it should be cut. Now here the second instrument is very important. When you are cutting, the nucleus can get lifted, and therefore the second instrument will help in keeping the nucleus down. Similarly, if you understand that the loop becomes a small one as you withdraw, but it does not completely close. So in the end also, very small piece is attached between the 2 heminuclei, and that's why you have to insert it again and withdraw, and that time the second instrument will help you in separating. So unless it is done, then you will have a mess of the things. So these are the various positions, the silver loops, specifically shown in immature cataract how it will look, even though we hardly use it there. Exiting the incision, it has to be done same way, lying flat, and it comes out the incision. One thing I forgot is that on the shaft there is a black mark, and that is the point till which you enter it in the wound. Now let us look at a case. So this is a case of immature cataract, grade 3. However, there was compromised endothelium. Now you can see that silver reflex going there. Allow it to expand, and yeah, it goes. You can see that silver reflex now. And now second instrument comes, so that you don't allow the nucleus to pop up. And then do second maneuver again. Separate the 2 nuclei. go on to the other side, again you do the re-chop and complete the procedure. I'll just show you the part of the video, the phaco, so that you understand that how easy it is to do the phaco now. Yeah, so it is divided into so many pieces that phaco is really very easy. Remember, the most difficult part for any surgeon, cataract surgeon, is the first chop. If it is taken care by any instrument, let it be my loop, it will definitely have positive impact on the surgery. Now this is another case where it's a hard cataract. The first one, there were a lot of cortex, so you could not see it properly. That is the why this second case is shown. So hydrodissection, rotation of the nucleus to be really sure. See, lying flat, entering in, and now we are expanding it slowly. Let it go underneath. Over here, the silver reflex may be muffled or may not be seen at all. Okay, and now the second instrument will come into play. Okay, so the chopping is done, and now the second instrument, the second instrument holding it. Second instrument can also be used to separate the two pieces, so that whatever that small attachment is there, that can be broken. So you need not do that maneuver of injecting and withdrawing again. And now this is the second part. We need not see that. What are the probable complications? It has a learning curve, but once you have done 10 cases, it is one of the easiest thing to use. CCC tear. Suppose we go while withdrawing. Suppose the small appendage between the two pieces is left intact, and we try to withdraw. It has got a capacity to either get the nucleus entirely into the anterior chamber or rupture of the CCC. Similarly, there can be floating cortex. So in a mature cataract, that is not much of a problem. But in the first case when I showed, because of the cortex started floating, it can make our view cloudy, and then we may have to re-inject visco and start operating again. If the silver reflex rule is not followed, then we can get improper cut. So you get one piece big and one piece small, and of course you can have AC collapse. For that, it is very important that the instruments are not pressing on the posterior lip of the incision. This is the paper which says that 110 eyes were done, 58 my loop and other phaco, and there is reduction of energy by 30%, 30%, and there is 20% less loss of endothelial cells. Thank you very much.
Very nice presentation, sir. And while the next speaker, Dr. Alkesh Chaudhary, sir, will just set up his laptop, would just like to talk about in which cases would you do this as a routine, as a part of your surgery? Or in which situations you would like to do this and which situations you would not do this?
Yeah, as I said that the most stressful part in phaco surgery is the first chop. So whenever the stress is more, I would like to use it. So fuchs dystrophy, compromised zonules, and hard brown cataract. I would not like to make it a kind of a all case scenario.
And while you are getting that loop and actually chopping the nucleus, cutting the nucleus with that loop, there is a tendency for the chamber to become slightly shallow. So in such situations, when there are the exact situations where you would not like the chamber to be shallow, fuchs, endothelial dystrophy and things like that, so that every fluctuation or shallowing also adds on to the cell loss. Although in the study it has said that 20% less cell loss is there, but that is one point where anybody who's starting off should be wary of.
Yeah, actually very important, but I forgot to mention in the lecture is that once you get that silver reflex thing, after that it is very important that to move it slightly downward. So the direction, rather than let it be slightly like this, that will ensure that there is no the nucleus not getting lifted, neither there is collapse of the AC because of the egress of the visco from the main incision, and then you can say. So that's what I said, that it has got a learning curve. but about 10 cases and you are done. Like you will do it properly.
Perfect. Thank you, sir. Thank you.
Under methylcellulose,
Sir?
under methylcellulose, these maneuvers.
Yes, sir. Methylcellulose.
Good morning, the IULs. So these factors responsible: preoperative, peroperative, postoperative, subluxated IULs, PCD, PCR, zonal dialysis, trauma, accompanying complication, inflammation, IOP increase, vitreous, retina damage, CME. Management concepts is basically back to front approach is best for these cases. Most of the cases I'll be showing without taking IOL out. So this was a one case 2 years back, operated somewhere, vision was 560, had a mild blunt trauma. Actually he had a IOL in vitreous with the CTR ring and the capsular bag all together lying in the vitreous cavity on the retina. So I manage it in a different technique using a fish hook technique. First passing the sutures for the fixing a SF IOL, and then I went inside making opening. You see inside I am trying to remove the after removing vitreous from the posterior chamber, and with the forceps I tried to remove this IOL. It was so slippery because of the capsule ring. So I modified technique, then fish hook technique. I just took a 24 gauge needle, bend it, and you see the 24 gauge, I just bend it. I went into the cleavage between the anterior capsule and the lens, then just hooking like a fish this lens IOL in the bag with the CTR ring all together. So you see lifted it nicely and removing it from the anterior root, trying to remove again, slipped with the McPherson's forceps, and next time I tried with the Lim's forceps, tooth forceps, and removing the IOL just with the light pipe holding from behind. And now you see I am bringing from the anterior root and using this tooth forceps, because first time when I tried McPherson it slipped down. You see this is the important part of the surgery. You see now with the lenses out, still the bag and CTR ring is there. So bag with the CTR ring is now out. So remove this lens in toto and finally fix the SF IOL. I will not go into that detail. So just fixing the SF IOL, and you see well centered IOL. And this patient post-operatively got 6/9 vision, and another IOL, opaque IOL, you see is just folding on its own. So I removed this IOL so easily. So it was so easy to remove this IOL. You see, just put it out from the back, and so you see whole IOL has been separated, and removing from the anterior root and putting another foldable IOL, 4-week IOL in the back, so I could place well. So sometimes these lenses, I have used many opaque lenses. Sometimes even if haptics are stuck, you just cut the haptic, remove the optics, then you can still use the bag. Pulling out those haptics, stuck haptics, you will remove the total bag, so no bag is left post-op. So another case, peroperative dislocation IOL. So I made a small this trocar and cannula in the pars plana using vitreous cutter, removing vitreous, just placing the IOL. So there was a space in the sulcus. I could place this lens nicely in the sulcus without removing the IOL. You see with the again dialing the other and just tapping, and then I come to know that's IOL in place. This was again post-PK IOL subluxation, So again, without removing the IOL out, sorry, this is the post PK. So I did a small sclerotomy. So I'm just entangling the hook between the two loops of the 10-0 proline and then fixing that IOL on the sclera. You see now nicely fixed IOL in the, so without removing IOL, without causing any damage to the cornea, you can still fix these IOLs very well. Another IOL, this was replaced by the iris claw. So this is another option. So there was no sport behind. So you can remove this IOL. Again, iris claw lenses are very easy to, this is the iris claw lens. Just go inside and just from I make two side ports, just tap the iris into that. These are posterior chamber again, so it doesn't cause any damage to the iris cornea, doesn't cause any damage. See the other side, going behind and tipping, and do the anterior vitrectomy in the end. You see nicely placed iris claw lens in the center round pupil. So going to this last case, this is multifocal IOL dislocation. Basically my purpose to show this video was, whenever there is PCR, whenever there is vitreous disturbance, don't put multifocal IOLs, because small decentration cause all. This is IOL lying on the vitreous cavity, just simply holding with the IOL forceps and bringing it out in the anterior chamber and taking out from the anterior root. See iris, so opening the sutures, already pre-placed suture, remove the IOL. You see careful, this IOL is multifocal IOL. So whenever, because small decentration, it will not serve any purpose. So you will be wasting that IOL, rather put a bigger IOLs like non-foldable, so which you can play in the sulcus or SF IOL or iris claw, whatever. So many options, you can do that. So post-operative care is inflammation, IOP, hypotony due to wound leak, choroidals. On each follow-up, please evaluate retina. Do's and don'ts: don't run after the dipping IOLs or the nucleus, because I have seen removing IOL even lying buried into the retina. So they are running after the IOL, then pressing the IOL and damage the retina, leading to detachment. Don't try another IOL without removing the previous IOL. I have seen that also, like one IOL already lying in the vitreous cavity, another IOL placed in the sulcus. Do apply extra suture to secure wounds to avoid leaking ports and the hypotony. Once I got a referral from the nucleus drop, IOL drop. So he didn't put any suture, the eye was almost collapsed. So even to give anesthesia and all this has become problem, and choroidals are the very high chances in those cases. So we can avoid these problems. Refer to the retina specialist without any delay, as early as possible. Timely right way intervention will give the best results. Whatever cases I have shown you, they are getting very good vision, 6/9, 6/12 like that, once they are timely done. Thank you so much for your kind attention.
Thank you, sir. That was indeed a very informative, very skillful talk. While I would like to invite Dr. Sonu Goel for his talk on optimizing patient outcome with presbyopia correcting IOLs. While he's setting up the talk, it's very important just to, when all these different situations of IOL displacement are there, it's very important for us to evaluate pre-operatively. We should have a plan ready in our mind when we go in and try to operate all these situations. Whether we are going to put what type of IOL, whether we are going to place it in the sulcus, or is there a bag available, is there a PC rent or not, is there a vitreous disturbance or not. Everything should be evaluated properly pre-operatively and then go in with a plan. Thank you, sir. That was indeed a very skillful and very informative talk. Thank you.
So a very good morning, and I'm really thankful for incorporating me into this symposia, and my great friend Dr. Vavika, Dr. Saumil, Dr. Alkesh. So I'll be talking on optimizing patient outcomes with presbyopia correcting IOLs. I'll try to put it as a debate because I just lost my slides, so whatever I could retrieve. So we all, as cataract and refractive surgeons, we all know that presbyopia correcting IOLs have become a great gambit in our armamentarium. And what we are looking at is a patient having 20/20 vision day one. So very important is the right selection. So right selection means the IOL selection as well as the patient selection. So for me, I spend more chair time when I talk to my patient and assess the requirement of the patient. So I think hearing from the patient and looking to his demand is what is very, very important when you're dealing with such hypercritical patients. Collecting preoperative data, and I use all my diagnostics whenever I'm treating these kind of premium patients. And for me, every patient is premium because at the end of the day, what I'm looking at is day one 20/20, whether I do a phaco or a refractive surgery in my practice. So K readings is very, very important. I think we all have aborted manual keratometers, but I think I have one of the keratometers lying, and in situations where I cannot, I go and sit and use this manual keratometer. Automated, yes, we all have an access, and I think all our IL masters and all our optical biometers have an incorporated K readings inside it. So topography is again very important because it gives me two major things. I get the axis where I need to actually locate my torics and the degree of astigmatism. I think these are the two areas where I will second on this topographer. I'll master, I have an access to both 500 and 700, and I think all the major formulas are incorporated. And most of the patients now that we see are post-refractive or maybe short eyes, long eyes, and I think that's the gray area where we actually need to optimize our settings, and we really need to look into multi-formula approach, and with our experience I think we can address and again translate to 20/20. OCT, yes, all my patients are there are subtle lesions in the macula which can at times be missed. So all these premium patients are addressed to OCT, and the macula is always assessed. And eye tracing, yes, we do all the angle alpha, angle kappa, and aberrations calculations. And this is one great tool which I would always subject for my toric patients preoperatively and postoperatively to assess the right location of the lenses. Meibomian analysis, yes, it's a great, and we have this lippy view. So any patient where we have any kind of dry eye, we would first subject these patients to the lippy flow, and then subsequently take these patients for phaco-refractive surgery. So I think this is one gray area which we actually need to see, because poor ocular surface is what is a great hindrance to 20/20 day one vision. You actually, after all this, now sit back and discuss with the patient. So my practice has boiled down basically to monofocals. Monofocals, I would always go for advanced monofocal and advanced monofocal torics. And when I go for presbyopic correcting IOLs, I think it is just limited to basically EDOFs. And EDOFs is basically to those patients who either have a bad macula, glaucomatous patients, or hypercritical patients, or patients demanding, and they are, night driving kind of stuff, abnormal size of pupils, and uveitic patients. I think these are great candidates for EDOF lenses. And the second subset would be those patients which desire a great distance near an intermediate, and these are those candidates for the trifocal lenses. And my personal choice, number one, has been the Ateliza, no financial interest. I think it's a great lens and it works very well. And most of these patients, I have hardly to find any patient cribbing for any photopic phenomena. And the second, I would a great fan of the Synergy from Johnson & Johnson. No financial interest. So, and then you need to actually put in alternative scenarios to the patient. So a quick work, what I do is follow this Dr. Hollady's corneal power decision tree. Patients are taken on a keratometer. If there is a standard deviation more than 0.2, assess for dry eye, treat the dry eye after 6 weeks, and then reassess, do a topography. If the patient's standard deviation is less than 0.2, check out the cylinders. If there is any toric, there's no toric, you can do any great formula on the 700, take these patients in the OR. If there is a toric, you need to assess, do a topography, assess the cylinder and the degree of astigmatism, and then calculate out what is the exact power required for these torics. So now our practice has shifted almost to 70% of the torics, because we normally take these patients anything more than 0.75, we would take this on a toric platform, and less than 0.75, we'll take these patients on an LRI on our femto platform on the Catalyst. So quick preoperative considerations: patient should have a strong desire, the age, They should be, looking at multitasking, and pre-existing ocular pathologies have to be ruled out. Hypercritical patients, yes, you really actually need to sit back, talk to them, and it's better to have no for these kind of presbyopic correcting IOLs with these hypercritical patients, because these are those patients who would actually waste your chair time, come back again and again, and crib, and these would be those dissatisfied patients because they actually do not understand what they want to know. So occupational night drivers sometimes could be a no for these the presbyopic correcting IOLs. So as I said, sometimes low myopes, this is something debatable, but this could be one where we actually need to discuss, because all these years they have been without glasses for near work. And pupil, yes, sometimes for these decentered pupils, traumatic mydriasis, subluxated cataract. So I would always assess these patients full dilated on the slit lamp to assess any kind of zonular weakness or subluxations, because any kind of moderate to severe subluxation would be a big no for these trifocals or presbyopic correcting lenses. Any kind of surgical complications that we have during intraoperatively, I think we should not have any ego kind of stuff there, and we should always discuss on the patient with the patient on the table, and we should always have an alternative scenario. We've seen a lot of patients having those dislocated not on the axis, and then patients complaining of glare, vitreous in the anterior chamber. So I think this is a big no. If you have an open bag and the lens getting decentered, I think the ego should not come in front, and these should not be taken on these kind of IOL platforms. So high HOA, large angle kappa and alpha. So if you see here, we do eye tracy on all these patients. So anything angle alpha more than 0.5 would be a big no for these kind of lenses. So on the aberrometer front, so HOA more than 0.7, coma, trefoil, tetrafoil, anything more than 0.5, 0.4, 0.3, and any fifth order more than 0.2 would be a big no. We always do a quick dry eye workup. A quick word about these lenses available in the world market. So basically boils down into bifocals, EDOFs, and the trifocals, and each one of them have their own merits and demerits. But between the bifocal and the trifocal, we have almost shifted to almost trifocals because of two great reasons, and specifically with the Athlesia, the kind of light distribution that they have, 65% for distance and 35% for near. I think that gives a great distance, intermediate, and near vision to all these patients. So the Athlesia Tri basically works on the LISA principle, where LISA is the light intensity distributed asymmetrically. So 65% distance light goes for the distance, 35% for the near, and the rest is for the intermediate. And it basically is pupillary independent, and the SMP technology is basically what it is, the surface, the lens surface. I'll just summarize. And the aberration correcting optics. This is the defocus curve that you get with the Athlesia tree, and great distance, a good intermediate, and a great near vision. And mind me, it works even in, none of the patients have complained of any loss of contrast in these patients, and photic phenomena I find is minimum in these patients. So a great presbyopic correcting IOL that we've been using, and thank you so very much.
Yeah, Dr. Sonu, it was the topic was very important topic you are discussing on. Just wanted to ask a personal question from you. Are using some lenses because you are not using anything for presbyopia reading?
Sorry?
You are not having any glasses for reading?
Me?
So, yeah. So
I'm still young. I'm younger than Somil.
Okay, one thing, just hold on. So I'm just starting that. So in case you get a presbyopia, which lens you will prefer for yourself?
So that is what I talk to my patient. The first thing, that if I had been in your case, because I drive maybe 5 miles in a day, I have a driver, and I spend most of the time in my clinic, in my chamber, in my house, and I love mobiles, I love iPads, and I love screen time, and I hate glasses. So I think the trifocal suits me the best to my personality. And I would still, if I have 1 in 100, if I have a photic phenomena, I'll still, prefer to have it rather than to compromise using glasses. So I think with all these modern trifocal IOLs, be it the Athlesia from Zeiss, be it Synergy from J&J, they work.
I agree. These are very good lenses. And I agree with you. But the people,
I think the biggest thing,
in case the people, the people who are driving, who are doing everything on their own, they don't have driver. So which lens you will like to
Still, I believe that those patients who are, occasional drivers, city drivers, their driving is limited to,
No, they are driving on their own.
So if, there are those patients who love driving and they are highway kind of drivers, I would take these patients on an EDOF platform, and no proprietary interest. Vivity works very well in these patients.
Yeah, I agree with
So
you.
I'm a great fan for these lenses because this works very good distance, very good intermediate, and then you may just give
And
a
I
plus
tell you,
diopter
once
addition.
both eyes are operated, because I have done a lot of these ADOF IOLs. So once both eyes are operated, so there's not issue of intervention. Even they can work for near also very well.
Correct.
So not like that they can't work for near. They don't have any issues. Only thing you have to very accurate with the biometry.
Yes.
And secondly, you should make sure they don't have any retinal or macular pathology.
Exactly.
Non-diabetic patients having likely to have diabetic retinopathy or early stage of diabetes, don't put any trifocals or ADOF lenses in those cases. And the most important advantage of ADOF, I'm telling you, is there is no loss of contrast sensitivity. Because with all trifocals, any matter, doesn't matter how good they are, you will have a loss of contrast sensitivity. ADOF will never have a contrast sensitivity. So in case I feel, maybe you feel that I feel ADOF lenses for the young people, otherwise they are the best lenses.
So I think you very nicely summarized the gist of my thoughts.
I
Very
want
well.
combination. One in one eye trifocal and one eye.
No, that's not,
Nice, sir.
because ADOF is basically monofocal lenses with the extended depth of vision. They are not multifocal. So you can't do that
So
combination.
in that case, the patient would come cribbing with the trifocal that they see the glare halos, because then the at the cortical level it doesn't get balanced. So these are not the ideal patients to be suited. I think Hoya recently launched their trifocals where you have geometric and geometric plus, where you can have a paired approach. If you at all you need a good near, I think they've shortly world is moving towards these kind of approaches. But EDOF with trifocal is strict no.
There is a button of swap displays on the top. Thank you.
Thank you, Sonu, for your excellent presentation.
Good morning, everyone. So today my topic of presentation is toric IOL, the different marking methods. I'm Dr. Swati Agarwal from Kolkata. So for any toric IOL to give results with accuracy and precision, the pre-op toric IOL reference markings should be spot on. So pre-op reference markings can be slit lamp marking, bubble marking, the freehand, the smartphone assisted, the digital marking, femtolaser assisted, and an intraoperative aberrometry. So coming to the slit lamp marking, the patient sits straight. For people who do not have very fancy instruments in their clinic, they can still go ahead with toric IOLs, and a fixed point is shown onto the eye, and the thin coaxial slit beam is turned 180 degree, and on a dry cornea with a 26 gauge needle or pen we can mark. Bubble marker is similar. We need to mark the 3 foot plate points, and after putting the speculum with the bubble in the center of the 2 lines, gently press the marks. But then this can again be cumbersome and the patient might not be comfortable. So freehand marking is one of my favorites. Like on a dry cornea, we put the speculum and the patient sits straight. So many people have a query that it might not be just 180 degree. So I usually shine the torch through both the pupils and see whether the patient is sitting straight or not, and mark only once. So there are many online apps to see whether they are at 180 degree, available on both the platforms, both on the Android and the iOS platforms. So there is a video here. Yeah, so this is a gyroscopic assisted marker. So once the app has been opened, if we pull the camera or rotate the camera 180 degree, the camera rotation can be shown on the topmost portion. And keeping the mobile rotation at 0 degree, we align the corneal reflex at the center, take a photograph, manually adjust the cornea within the circle, manually align the cornea within the circle, then press the protractor sign at the right bottom, drag one point through the mark and the other point through the center of the circle. So when we're drawing the red lines through the mark, it has to be at the limbus. It's not beyond the limbus, not on the cornea. So that is where the mark should be, and the mark should be as thin as possible. So coming to this marking, the marking in the theater, on a dry cornea, we're marking with the Mendes ring and an axis marker, and again depress the instrument gently and mark the incision only once. Coming to the image guided systems, the variant measurement unit, no financial interest here, with the near infrared LED lights measures the sphere and the cylinder power of the central 2.8 millimeter of the cornea, and it takes into reference multiple reference points on the conjunctiva, the limbus, the scleral vessels, the iris features, and creates a digital overlay between the live surgical image and the images taken preoperatively. And then the data is passed on to the vision planner and then to the variant digital marker. So this helps in reducing any surgeon-induced or assistant-induced transcription errors, which is very important, as we've just discussed the few talks back. So over here, this image guided virtual marking can be seen. We also get to see the rexis after rexis marking is available, and the cataract is just proceeded as like a normal cataract. And even for the IOL implantation, we get the axis, and the IOL is implanted on the axis accordingly. So there has been various studies like digital image guidance delivers better outcomes than the slit lamp assisted and the conventional manual ink marking techniques in terms of astigmatism. But as far as the smartphone assisted versus the image guidance has been done, like in my hands, like we've done a paper, and this was also like this won the best paper of the session at AIOC 2 years back. So the results were almost accurate and at par. So coming to femtolaser second marking, so this can be corneal marks, capsulotomy marks. I've not seen anybody doing capsulotomy marks. What we go for is the corneal marks. So what is done is initially a freehand marking is done, and that can be confirmed to the reference markings either with a smartphone or a pendulum marker, whatever is comfortable in the surgeon's hand. And then the LOI is the 0-180 degree marking, so the LOI is aligned with the reference marking accordingly. And thereafter the docking is done and the femtolaser proceeded. The K readings are already fit into the catalyst nomogram, and the axis and even if you're going to plan for arc weight. So over here, as we can see, yeah, so this is after the rexis has been done. So I'm applying this Mendes ring and the axis marker here just to cross check whether the femto marks are accurate or not. And if we can appreciate, there's a faint glow under the reference markings, under the axis markings. So those faint glows are the femto axis corneal marks. So they very much coincide, and almost all my cases I've seen, they are superimposing, and it's very much accurate in all the cases I have been seen so far. And this corneal femto marks also helps in the post-operative period to see whether there's no IOL rotation in the post-operative period. So coming to the intraoperative wavefront aberrometry, it's a real-time measurement, measures the aphakic, pseudophakic refraction, and helps to choose us the IOL power. But again, the results can be skewed with surface changes, OVD choice, IOP maintains speculum pressure, and finally it's again guesstimates the ELP. So I would like to sum up with, let's walk with the present and eye the future. Thank you. And I would like to invite you all for the AIOC 2024 Kolkata for the upcoming next year.
You give us a room in the venue. You give us a room at the venue. Then we'll come.
Perfect, sir. ITC, Sonar Bangla.
Thank you. I have a question. Next speaker is there, Dr. Ravi. We don't have. So, see, when we are talking manual marking, freehand marking, once you have done the marking, put the patient on a slit lamp and measure the axis of that marking. Okay, that will, because sometimes it is not 90, it is 87, or 180, 177. That is one thing. Second thing is that when your variant and all these things will work, provided the head position, chin position, the marker on the vertical bar and the alcanthus they are meeting, all those points should be told, because the position of the patient is very, very important when you are working.
For the femto, when the patient is lying down on the
variant, actually, the clinic. Yes. Thank you.
Thank you, sir.
Yeah, sorry. So this sir was also saying that reference marking is very, very important. So once you're doing the reference marking, first is your 90-degree marking. Just make sure that 90-degree marking is at a proper level. So if we are doing, sometime we are doing all the three markings simultaneously, what happens? It may be straight, but sometime it goes down. So it is not exactly at the 180 degree. Sometime it down to 160, 150 degrees. So lower marking sometime do, which causes a lot of problem doing the final marking on the. So first you do the 90-degree marking at a proper level so that it covers the cornea nicely. So taking again that into reference, do the 180-degree marking. So they are exactly on 180 degree. As sir was saying, do make sure again with your that measure that marking is at 180 degree or not. So that's very important. Thank you.
Thank you.
It was an important topic, and marking is one of the sources of errors in the final toric IOL outcome. It's one of the errors where you are going to align the axis of the IOL, whether it's going to remain in place or not. There are so many other sources, whether the keratometry is appropriate or not, the head position when you're measuring the keratometry, whether it's tilted or not. There are so many sources of errors. This is one of them. And although we are, of course, nitpicking on whether we should do freehand marking or slit lamp based or Varion based or all these things, we are really going deep into that 1-2 degrees off axis, etc. We should also, but ultimately, toric IOL, we have to remember, it's a very forgiving surgery with forgiving outcomes as well. So overall, with all our marking systems, whatever we do and wherever we align more or less to the same alignment of the IOL to those marks, the results are very decent, I would say. We don't get too many toric IOL surprises in such terms. So although we are talking about marking, we should go be very particular, but at the same time you have to remember that it's quite forgiving as well. Thank you so much. Indeed, a lovely talk.
Especially with the premium toric IOLs, this becomes very important.
Thank you, sir.
Lovely.
Thank you.